morning, everybody. I talk about two single-dose Oritavancin in the treatment of acute bacterial skin infections. Definitions: Oritavancin, a second-generation glycopeptide, as treatment for acute bacterial infection of the skin and soft tissues caused by susceptible gram-positive bacteria, including methicillin resistance, Staphylococcus aureus. In single dose, it proved to be non-inferior to vancomycin in acute bacterial infection of the skin and soft tissues, with a similar safety profile. Its potential advantage over other therapeutic alternatives will lie in its administration in single dose and in the lack of need for monitoring plasma levels, which will make its ambulatory administration possible, and in the improvement on adherence.
Because of our shared mindset, ICPD scientists often see opportunity where others do not. An example of this can be seen in the story behind Oritavancin, a drug that may not be on the market today if it wasn't for the science of PK/PD. Eli Lilly discovered Oritavancin a quarter century ago, and like many long half-life drugs, they tried to develop it as a once-daily regimen. But for some reason, they couldn't get it through phase 3 trials. So in the early 2000s, Oritavancин's development was taken over by Intermune, and they too tried to develop it as a once-daily regimen. Not seeing Oritavancин's potential, they decided to refocus their company and sell it to Targanta. Targanta continued developing it as a once-daily regimen and invited us to work with them. However, after carefully evaluating the PK and PK/PD profiles of Oritavancin, our teams realized that the solution was not to administer it as a series of small daily doses, but rather as one big single dose. Targanta decided to shelve this idea now, but explore it later, after the once-a-day regimen got approved. So they submitted it to the FDA for approval, and after many months, the FDA came back with a rejection. Daily doses of Oritavancin weren't that effective. Seeing the potential in previous PK/PD data, Oritavancin was then acquired by the Medicines Company. With ICPD support, they conducted further clinical studies to put this novel regimen to the test. With the data from these trials in hand, the Medicines Company submitted Oritavancin to the FDA as a single-dose regimen, and success. On August 19, 2014, the FDA approved Oritavancin as the first single-dose regimen antibiotic for complicated skin and skin structure infections. Reflect on that for a moment. The exact same drug was submitted twice to the FDA, yet it was the dosing regimen based on PK/PD science that made the difference between rejection and approval. This is what we mean when we say that PK/PD is essential to drug development. And in some cases, it is the difference that determines whether a valuable drug makes it to market and benefits patients. After all, isn't benefiting patients what drug development is all about?
Applications in medicine. Two recent articles in the New England Journal of Medicine offer hopeful news about a potentially less burdensome course of treatment for the approximately 50 million skin and soft tissue infections that occur each year. But the studies test drugs whose mechanism of action is similar to vancomycin, the most common in our therapeutic arsenal for skin and soft tissue infections. These semi-synthetic antibiotics called dalbavancin and oritavancin do their job by blocking the steps by which gram-positive bacteria, such as Staphylococcus break their cell walls. Because the drugs have a longer half-life that allow for weekly dosing, they could be a desirable option for patients and for healthcare providers when overcoming the burden of twice-daily dose on intravenous antibiotics.
ABSSI, or acute bacterial skin and skin structure infections, have a huge economic burden for our hospital, along with a huge clinical burden. Many times patients have to get admitted, and then a lot of times they require IV therapy for a few days and then get discharged, and it requires the patient to take oral antibiotics. This requires the patient to actually take those antibiotics, and sometimes that doesn't always go as planned. The economic burden for these infections is large in the sense that they get admitted and a lot of times readmitted for that same infection. Oritavancin and vancomycin are similar in what they cover. They both cover gram-positive organisms, including staph and strep that live on your skin. In terms of administration, though, oritavancin is a single dose, whereas vanco has to be given either once or multiple times a day, depending on the patient's renal function.
Pros and cons. Pros. From a clinical point of view, single-dose Oritavancin has been shown to be non-inferior to vancomycin in skin and soft tissue infections in controlled studies, with a safety profile similar to that of the comparator. Cons. However, its longer duration of action could become a safety concern in case of intolerance or hypersensitive reactions. The long elimination half-life also raises concerns about the emergence of resistance, particularly when the drug concentration falls below the MIC for the tested pathogen. Issues applied in Ecuador. They are not currently marketed in Ecuador except for levofloxacin and have properties that compare with previous ones, have advantage over the previous one's properties that compared to the previous one have significant advantage as they have a broad spectrum advantage, with market activity against gram-positive and gram-negative bacteria, including anaerobes and gram-positive and gram-negative bacteria, including anaerobes and intracellular pathogens. The increase in activity against gram-positive bacteria constitutes a significant therapeutic advance for quinolones, significant therapeutic advance of third-generation quinolone. Conclusion. The efficacy and safety of oritavancin is comparable to existing alternatives in acute bacterial infections of the skin and soft tissues and does not improve the cost-effective rate. So the proposed positioning will be the treatment of vancomycin-resistant enterococcus infections in adult patients when the use of linezolid or triglyceride is contraindicated.
I got it. So at our institution, we developed a protocol for appropriate use of oritavancin, and one of those implications in that protocol is using oritavancin to expedite patients who are admitted inpatient to expedite their discharge. So in this study, we looked at patients who received oritavancin to expedite their discharge, and we looked at patients who received conventional treatment with vancomycin and oral antibiotics. In terms of cost avoidance, even though we spend a significant amount of money for the medication, which is about $2,700, we save money in the long run because we are reimbursed based on DRG or diagnosis-related group. And for us to receive that, it doesn't matter how many days the patient stays in our hospital, we get the same flat rate. When the cost of a hospital admission is $2,750 a day for a patient to walk through our door and sit in the hospital, not including any labs or tests or drugs or nursing time, and we only get reimbursed about $5,400 of that, we want to try to match that as close as we can. In terms of clinical implications, by using oritavancin, our patients have less time in the hospital because we're using it to get them out. A lot of times we keep patients inpatient to just give them IV antibiotics because we maybe don't think that they'll take oral antibiotics, or they're have too severe of an infection to take oral antibiotics. So we keep patients in the hospital longer just to give IV antibiotics. But the oritavancin completely eliminates the need for patient compliance. We give them the once infusion, and the patient receives antibiotic treatment for the whole course as they would staying in the hospital with IV. Additionally, patients have less recurrence of infection, as we saw in the study.
Thank you.